Hello, everybody, and welcome back to the ARPneuro Q&A show. My name is Jake. I am your trainer, and with us, as always, is the man, the myth, the maverick, the pickleball bad boy himself, Matt Dell. Good to see you again, Matt.
Jake. How we doing tonight, my friend?
Doing well. It's another Monday. Who's your pick?
I think I'm liking the Jets tonight.
Yeah, that's mine too.
Taking the points.
I'm taking the points of the Jets.
I like it. I think their defense is going to step up. So
yeah, I agree with you.
We shall see. Well, welcome everybody. Excited about the tonight's show. I've got a ton of questions that PRS owners have already been texting me. So I'm excited to get right at it, Jake. And I think we'll have a pretty good audience tonight. So
I love it. You're always the man who's not afraid to ask the tough questions. So if it's above my pay grade, I'm just going to defer everybody to info@arpneuro.com. But you can always ask us questions there. You can ask us questions if you're live, right on the side, just where you can post a comment. And if you do have access, sometimes we can receive them through text. Don't text me, all the buddies, because that throws me off. And then I'm trying to read it. So let's go ahead and get this fired up. What do you think, Matt?
I love it. Yeah. So I think just want to give a little bit of an overview of ARPneuro. The technology that we're going to be talking about has been around for quite a while. It's been about over 20 years in the U.S., huge success rate, primarily developed for professional athletes and really much quicker than traditional physical therapy to recover. And really preventative as well, Jake.
Absolutely.
So as I mentioned, you've probably seen it if you've gone to our website. We've got a lot of stories on there on athletes using ARP, a ton of videos from NFL Today and all kinds of different athletes taking advantage of this technology to heal and get back into whatever sport it is. We're now bringing this down to weekend warriors, collegiate high school athletes. As a tool that's been around for so long. So excited about that.
And some of our best customers are those weekend warriors. So keep that in mind.
So we have two products. We have the RX100 and the PRS. The both same technology. Really, the only difference is the RX100 is a Class 2 medical device and can contract up to 500 times per second. And the PRS is an over-the-counter, can contract up to 245 contractions per second. And we're going to primarily focus on questions today for the PRS.
Love it.
It's been utilized. You'll start hearing a lot more. Kaiser University, they're diving deep, doing studies, very involved in helping with evaluating protocols and some very exciting things. As a matter of fact, Jake, I think we're going to try to get Dr. DeBono on one of our Q&As upcoming. Is that correct?
That is very correct. He does listen to these, and we were talking about your favorite word, the compensatory pattern.
Yes.
And it's funny, he called me up, and he's basically screaming at the monitor, waiting for me to say substitution pattern. And I didn't. So he kind of talked about that because we're just so enamored with compensatory. He said we were close, but he wanted to go into detail about substitution patterns. So we can get into that. But yeah, Dr. DeBono is hopefully going to be on here eventually and, help us chuckleheads out, so he would say, and answer the questions a little bit better.
We're going to have to table that compensatory and, when we get into the training. So good stuff.
Sounds good.
Next slide.
Thanks, Matt. So kind of to segue off of the Kaiser is we're focusing on I'm calling this the calf protocol, but anything with calf pain and a lot of that going into spasms, strains, tears, tightness. And of course, there's always that beautiful recovery that we have from our technology. So what you're going to discover from these pad placements, they're a little bit against the tradition of how we used to set this up, 5 years ago using this machine. But that is also because of what Matt talked about is we are in Kaiser, there's research being done, and we are finding better ways, better protocols, and better pad placements to actually, focus on this and treat some of these areas. Now, this is predominantly focusing with the RX100. Now, kind of going off of what Matt said, we are answering a lot of questions with the PRS. You can technically kind of do this or to some degree with the pad placement with the PRS. But this specific setting is definitely for the treatment aspect of it. So the starting point, you can essentially do this with the PRS or the RX, is, dealing with any type of calf pain, muscle spasms, tears. For the first lead or the first channel, however you want to call it, you'll have the black pad, as you can see here on the gastroc, and then the red pad on the bottom of the heel. We're kind of, it's doing something a little bit different than your traditional sandwich point, where we kind of had the black and the medial and the red on the lateral. We actually place the black now on the pain area and then find some sort of anchor where it's covering that territory. So in this case, that's why we have it on the heel. So that'd be the first channel. On that second setting,
Jake, could you go back to that for a second?
Absolutely.
Just out of curiosity, as we're looking at this, for those out there, what is the difference of a calf tear versus cramping, and how can this technology take advantage of, let's say you're a heavy cramper in your calves for whatever reason? Is there something going on there?
Yeah, for sure. So let me talk about the cramping, because that's probably going to be more common with just about anybody. I'm sure we can all experience the cramping sensation or even muscle spasms, and that a lot of things can cause that. Some of it could be dehydration. In some cases, it could be somebody taking up a new activity. We kind of talked about that, Matt, when we were going over pickleball, and where somebody hasn't done something physical for quite some time and they go into this new sport, and this could possibly cause some cramping. And then sometimes it just could be some sort of mineral deficiency, lack of calcium, lack of magnesium, even potassium. So, those things can certainly they're the most common that will create some sort of cramping or muscle spasms. Yeah,
definitely
please.
not the most enjoyable thing to have in the middle of the night. I don't know if you've ever had one. Have you had one?
I have, and it was because of overuse, and sometimes
Yes.
you can get that as well. And you wake up in the middle of the night, it's absolutely miserable.
Yeah, that's scary when you feel it coming and you wake up, for sure. So
yeah, 100%.
Okay, so we've got the black just below the knee and the red on the bottom of the foot.
Correct. And just kind of, it's that calf muscle, right? So you can actually adjust that. Sometimes I do recommend, if it's the first time that they've been on this machine, if a doctor's treating a patient, or even if you have the PRS for the first time, sometimes I recommend you go a little bit higher. So what I mean is sometimes right behind the knee, and it's that area called the popliteus. And the reason for that is when it's directly on the calf like that, it does hit it very hard. It can cause the calves to be sore for quite a long time, 2-3 days. And sometimes that makes people miserable. So if somebody's not active, a lot of times I'll raise it a little bit higher to the popliteus or behind the knee.
And really, there really isn't a bad placement, correct? I mean, you can almost, as a owner of a PRS, you can actually experiment a little bit and kind of play a little bit, if you will. Obviously, you want to try to be in the general vicinity, but tell us a little about that.
Yeah, thanks for bringing that up, because when you ask that question, that does give doctors the permission. Some don't need it. Some like to break the rules, but I think some people need the permission to say, hey, these are the pad placements that we've discovered that are the most successful. Mm-hmm. It doesn't mean other pad placements won't work. This is just what we've discovered has worked better. Now, that being said, I want to pause to say, new protocols have been developed by going against the rules that we've had in the past. So to your point, there really isn't a placement that's going to technically be wrong. There's only placements that are going to be better or more successful than others. Now, as we continue to kind of delve into this new direction where we're working with Kaiser and Dr. DeBono and a lot of his students, we are finding some very successful new pad placements that, this is one of the reasons I'm putting it within the training.
So. I love it. Yeah. And I think, and just so the audience knows, I mean, it's not only just the success and help that we're getting with both Logan and Kaiser, but we've got over 90 clinics across the country, and you're in probably constant communication with those clinics as well. Correct, Jake?
Yeah, 100%. They either reach out to me or I'm reaching out to them. We're doing constant training, or it's essentially just texting or email communication of
fine tuning kind of the protocols. I love it.
Correct.
Good.
And we do have a question coming up here. I'm going to pull it up by Ryan. Ryan asks, what would be the pad placement if I had pain in both calves? It's a great question. So I'm going to get into further slides that's going to show some detail. But what I would say is we would pause the next lead, and we would just place the same pad placement with the other calf. And we would dispense of what I'm going to talk about next. So essentially it would be the same thing, black on the calf and then red on the bottom of the foot. So good question. All right. So on this next lead, this would be essentially, again, now going back to just the one calf pain. This second lead, we would have the red pad on pec minor, which is the opposite side of the calf that we are treating. And then the black lead would be on the inside of the leg, which is kind of your adductor area. It's not on the quad adductor inside. So that graphic's a little bad. Who does our graphics on this? Matt, can we fire this guy?
I think it was you, so that would be tough to do, but
can't be me. Well, anyway, it's not very close, but it should be adductor. I don't like that pad placement for some reason now that I look at it. So this is kind of the look here. As you can see, we have 3 pads. This is, I understand this is a lot different than the way we used to set this up, but they've had tremendous success. I've used it myself today with my hip and kind of doing this middle cross pattern. And when I say middle cross, that's essentially the red pad on the pec and then the opposite adductor with the black pad. And then of course the other 2 pads are working that calf muscle on that left side in this particular diagram. So
it's kind of interesting, just out of curiosity. We're talking about calves, and then you've got pad placement all the way up there. Explain that a little bit. How and why does that work if I'm working on my calves?
Yeah, that's another really good question, because there's a couple of components to that. The first one is what we've always talked about is a lot of times where a lot of that pain area is taking place is just the symptom. Very seldom is that the actual location where the problem is at. Oftentimes that breakdown point does go back to this substitution pattern of some other muscle that perhaps shut down, and then there's these other dominant muscles that took over that creates, compensations. So this one particular, Dr. DeBono goes into the middle cross patterns, and this would just be that anterior sling of hypertonic muscles. So that red pad on that pec minor is that secondary pad that is now having that communication, that upward current where that black pad is or that adductor is. And the premise behind that is about 80%, we believe, of the muscular breakdowns have something to do with your core, essentially, or your middle cross. And that is where this pad is basically covering. These 2 pads are hitting those locations. So if there's some sort of breakdown, this communication between that black pad running up to that red one in that pec minor is going to be able to hit all these muscles in that middle cross area of the core, wake them up. If there's something not firing, this is going to help correct that. Now, this secondary placement is actually new to me as well. This is what Kaiser came up with. Dr. DeBono in his brain decided, let's actually hit that pain area as well as this middle cross. And they've had tremendous results with that.
Very exciting. Awesome. We've got quite a few big audience. We've got some questions flying in, Jake. So
all right, maybe I should stop talking and maybe answer some questions.
I love it. I love it.
So here's one. Rachel asks, can you talk about how partial tears in your shoulder can heal with ARP and where the pad placement should be? Okay, this is a loaded question, but a good one, because I do like shoulder protocols, especially with our technology. Now, we've had success with with muscle tears. Now, people believe that because there's a tear that there's no way to repair unless you have surgery, and that's not entirely true. So you have certain grades, but eventually when it's a full tear, there's not much we can do other than getting blood flow until surgery. If it's not a full tear, we do have an ability to get blood flow into that location and help essentially repair that area. So if you can kind of go with me over here to Stretch ARP Strong.
Love it.
Let me show you here's a common pad placement with shoulders. Now, There are several good ones, but one of the things I like about, and thank you, Sarah, for putting that big screen on. This is why she's amazing in the back end. It wasn't her that did this graphic; it was me. She's too good for that. So I'm going to flip stretch around. There is a pad placement I particularly like because specifically it works and it keeps the pads on without having to secure them too hard. So it's essentially taking the black pad, and we're going to go just behind the shoulder here. We can call that infraspinatus. And then flipping stretch around, we're going to go medial bicep. And the reason why medial bicep, that's still going to help. It's still going to be a breakdown point a lot of times when you're having some shoulder issue. But one of the reasons I like these two, medial bicep and posterior delt, is one of the problems we do happen to have is that these pads do fall off on shoulders. And when you're going through movements, whatever it is, it's on a ball and socket, and that pad tends to wrinkle up and then it falls off. For instance, when I have this on here and I'm moving this will tent up and come off. When we have it on medial bicep, I have the ability to basically wrap this so it's secure. When it's on the back, like infraspinatus right here, usually a shirt or even a compression shirt or even some sort of like KT tape secures this because it's flat to the back. But those two pad placements do a great job. There are others, but that's the two that I like to kind of recommend the most.
Yeah, Jake, it's interesting. I've got I talked to a PRS owner today, and he has same exact issue. Initially, he got pain relief and said that he's still kind of fighting through his shoulder issue. And I said, without question, if it's not going away, you have to kind of text us at info@ARPneuro.com. It's probably pad placement, and more importantly, there's probably some compensatory issues or something that's not firing somewhere else. And that's why we have such a extensive library. And more importantly, at that point, it's probably pad placement, and obviously there's some other areas that need strengthening. Is that pretty accurate?
Yeah, that is very accurate. And that causes me to kind of go back a little bit. I don't want to leave the impression that pad placement isn't important. And especially when you get into a lot of the treatments, pad placement could be the significant difference of fully getting someone healed and then just relieving some pain temporarily. So you're right. Sometimes when that pad placement or for a better term, when that movement isn't seeing that improvement, pad placement could be one of those key factors. And yeah, we do have a lot of those options. This was being one of them, but there's other multiple placements that perhaps might be better, just depending on what injury you're going through.
Excellent. Thank you.
Absolutely. This is another good question, kind of getting in. I didn't talk about this with the pad placements, especially with the protocols that we're going over today. But Stephanie asked, can this pad placement work for shin splints? And the short answer is what I gave, black pad on the calf, red pad on the heel. Sure, it could. That's not the best pad placement, though. So we're going to go back over to stretch Armstrong here.
So before you do that, Jake, because I think everybody on this has heard of shin splints, but I don't know what that is. Could you explain exactly what a shin splint is and what causes it?
Any runner knows exactly what they are, but I'll kind of explain it. And sometimes it just could be a whole host of things. Sometimes it just could be over quad use, or quad is taking over and you're putting a lot of pressure on your feet or your heels. If it's a lot of heel pounding and running, you get this really painful sensation right alongside of your shin. And it could be a whole host of reasons. But for the most part, there are some placements that we can do to kind of relieve that pain, but it can become extremely painful to walk, especially for runners. And those runners out there know exactly what I'm talking about. I've dealt with it before. For me, I think a lot of it was because of a heavy heel strike, and I had to learn how to run a little bit differently. And the shin splints kind of naturally went away. So good pad placement. Let's say black pad. We're going to go on tibialis anterior. So if you can see closely here, just kind of assuming Stretch's left shin was bothering him, we're going to go long ways on tib anterior. And then I'm going to flip that around. And I actually, for this one, I like to go long ways kind of where the gastroc and the Achilles meet. So this would be the red pad, gastroc, Achilles, kind of in that section, and then over here, tibialis anterior. Now, this would essentially take the place of that first pad placement that I showed everybody, where we had the black pad on the calf and then the red on the heel, specifically because we are targeting shin splints. Now, to that point, this secondary lead that we get to, we would still do that middle cross pattern, but with this as the pain placement, so to speak, to kind of cover that shin splint issue.
Excellent.
Does that make sense?
Yes, absolutely. Now, yeah, great question. Follow up from Stephanie on the PRS.
Can I do calf protocol with the PRS? Let me show this. Did I pull that? Oh, yeah. Yeah, absolutely. Again, it would just be with those specific placements. It's going to be a little difficult to do use it with the PRS when we're working this middle cross portion. You can run that pad placement, but it's not going to be as successful. The PRS is not designed to treat, so to speak. This is ultimately going to be where the RX is going to shine. But I'm not going to tell you can't set this up, because with the 4-lead system, you certainly can. So I do recommend you try it. The one difference is, and this is a very important difference, the RX runs on two channels. So you actually have a 4-lead system. The PRS actually runs on one channel, where we do have a 4-lead sort of adapter system where we can spread those 4 pads out to make it a 4-pad, but it's still traditionally a 1 channel. So crossing the pads is going to be a little bit more difficult unless you're doing it one at a time, meaning I'm crossing with my red and the black on a 2-lead system. Okay. Did I confuse that, or did that make sense?
I think it confused everybody, but that's okay. Keep going.
All right, wonderful. That's what I'm here to do. info@ARPneuro.com. We're here to confuse you. If you do need some clarification on that, let us know. And I'm going to handle this. We do have a lot of questions. Ryan comes and asks, how many days per week do you recommend the calf protocol? So this recommendation would be with just about every protocol we have, bare minimum 2 days a week. If you're working with the PRS, you can essentially do this every day. And if you're coming in, you're seeing a doctor and you're getting treatments, minimum, I would say 2 times per week. Now, some of them come once per week and you're still going to see some benefits, but that's going to take a lot longer than if you came in twice a week. And I would say if you can come in 3 times per week, even better. So good question on that. And then finally, unless I skip somebody.
You skipped Adam, your friend Adam. He had
another one
where he's throwing out a.
Oh, I ignored this one on purpose, Adam, but let's go through it anyway. Tried this cross with Jake a few weeks ago, healed over a few minutes, but once the body was able to adjust, this workout was intense. 40 pulses per, that PPS is pulses per second. 35 minutes on this was like a full 2-hour workout. I do remember that. We did kind of test on very high numbers. Luckily, Adam's able to, get really good intensity so we can get good readings. And he tested this before we started using it. And he's kind of referring to like where the foot bath goes with a lot of this as well. And from what I remember, he loved it, but he was sore for a while. So just keep that in mind with the 40 pulses per second.
And that's a good sore. Is that correct, Jake? When you say sore?
Yeah, it's, in the fitness community, we call it DOMS, which essentially just means delayed onset muscle soreness. And that's essentially just from, that muscular breakdown of what you get from a hypertrophy or strength training. So no different than when you were to work, if you were to work out and you haven't worked out for weeks and you finally go back to it and you're like, oh, my arms are sore. That's just them rebuilding. You're tearing those muscles, but they're building back. So it definitely is a good soreness. Much different than pain.
Good.
And here's one more from Adam before we get back into it. The foot bath with the cross at 40 pulses per second is way more intense than at 500. Entire lower body felt overhauled. And he's correct. When, to kind of give you an idea of the pulses per second with the RX, on the lower numbers, the 40 is almost like a massage. It doesn't feel that heavy. But when you start to get into the more intense numbers, the 20s and 30s, and this machine can go up to 100, the 40 really hits like a hammer. And that's truly where we're seeing a lot of that strength training take place. Now, it doesn't mean you can't get strength from 500, because you certainly can. And it also doesn't mean you can't get movement from 40, because you certainly can. But there are some benefits in doing both. And when we get back into this protocol, I'll explain how Kaiser has been using it by actually adapting both of them for different reasons into that same protocol. So yeah, I'm glad you brought that point up. I'm going to jump back into this. And that's exactly what I wanted to talk about here is with these pad placements, whatever movement you chose, and let's just assume that it was in fact maybe shin splints or something to do with the calf, perhaps standing calf raises would be the most beneficial. If it's a patient that they probably didn't want to, or they couldn't put a lot of pressure on their joints, I've had them lay down in a supine position and then just do your traditional plantar dorsiflexion. So you're just moving your ankles like this. So you don't necessarily have to have pressure, but if you can get your, on your feet and actually move that way, even better. Now, as you can see here, this first set would be 2 sets, 10 reps, 40 pulses per second. So that's that heavier one that we were talking about, that Adam, referred to. But it's literally more harmonious, or at least more relatable to what your brain does. I think your brain does it between 10 to 20 times per second. So 40 pulses per second is a lot closer than 500. So you're sort of ramping into those higher numbers. So after the first couple sets, staying on normal polarity, 2 more sets of 500 pulses per second, and then we actually hit the reverse. A lot of times I recommend you turn that down. You don't want to hit the reverse while it's at its highest power, especially with a patient. But you turn it down and then you build it back up with those 2 sets. And then the final one, which would be the 7th and 8th set, you turn it down again. You go to 40 pulses per second. You're reversing that polarity. I don't think I said that with 500, but you're doing that on that 3rd set. Keeping that polarity reversed, but now you're kind of finishing it with 40 pulses per second, 2 sets of 10 reps. And then, of course, what goes along with this is always foot bath. We kind of talked about this over the course of all our other Q&As. And I know I kind of tire this out, but foot bath does go really well with any type of like movement that we're doing, especially when it comes to knees, ankles, feet, calves, anything in general. And especially I've treated shin splints just doing the foot bath. Basic setup, black is on the bottom, crossing the pads. Showed this before using the clamshell, and you just wrap it to the patient's foot. Traditionally, it's on the arch. Sometimes we'll go on the heel or we'll go on the toes. It just depends on what they're going through. If it's a plantar fasciitis, a lot of times I'll go closer to the toe box and just kind of work it there. If it's neuropathy, sometimes I'll go closer to the heel. Just kind of, again, depends on the patient. And then you cross that to the opposite quad and then have at it 20 minutes. And traditionally now it is at 500 pulses per second. If there is, however, a patient that has been through this multiple times, 40 might see some more benefit. Adam was correct. 40 does hit differently. And I kind of like it for someone who has an extreme case of neuropathy that's had a hard time getting any sensation at 500. I believe 40 would probably change the course of that. So something that is definitely worth trying. And I do see a question here. What kind of movements do you recommend with the calf protocol? In case I didn't answer it, calf raises are a good one. Laying down, plantar dorsi, but anything, if you want to get more advanced, a lot of times if it's an athlete, I'll have them go through their specific moves, whether it's a pitcher or, if they're playing football, doing what they do best is probably one of the best things you can do, because that's their livelihood. And that's usually the movement I have them do. But for anybody else, it's kind of play that by ear. I think any type of movement is better than not doing any movement at all, especially for our technology. It's a good question. Did you have a question, Matt?
No, I'm just realizing that 30 minutes has flown by and my alarm clock is about to go off, as you know.
I know it's past Matt's bedtime, and I have a New York strip steak waiting for me. So I guess we could put this to a close. I'll answer one more question. I know we've skipped a lot today, but first off, thank you for all the questions. This is really where we get the best out of it, because it's those questions that sometimes we can easily overlook, or they're not asked. When you ask it, it gives us an opportunity to answer it, and other people will benefit from that as well. If you had the question, there's a good chance somebody else did as well. But I want to talk to Dr. Ted Arkfeld, who, by the way, he's our protocol king when it comes to any type of like concussions. Definitely our go-to guru, up in Michigan, where he's working with a lot of the athletes up there, and has come up with a lot of unique things with concussions that he had a lot of success with. And he asked, can you put them on a BOSU ball? This is fantastic, and absolutely 100% you can. In fact, I do have a video of you, Dr. Arkfeld, if you're still watching, where you do have them on a BOSU ball. This particular athlete happened to be using the PRS, so you can use either one. And it was a post-concussion, but getting her out of, I believe at this point, she was out of the concussed state, or getting out of it, and now into that movement, which would have been those next few steps for her. And that's where a lot of that creativity came from. So that being said, I also know that Dr. Battaglia out of the Chicagoland area uses tiny BOSU balls with just about every one of his patients. So it's interesting you brought that up. It's becoming more and more prevalent. I think balance coupled with this technology is just it's a definitely a nice combination. So good question. Matt.
Wow, Jake, that was, you jammed in a lot of stuff in 30 minutes, my friend.
Yeah, I did. Thank you for the questions.
Unfortunately, we got many questions that we'll have to table for the next time. But here's the question I have for you, and I'm hearing this. Where can I find all the protocols in the library for both the PRS and the RX?
That is the best question of the day, and that was my last slide. Bad picture there. Again, fire the graphics guy. But it is, if you go to ARPneuro.com, how to use a PRS, this is the image that you will see. And you click on any one of these categories, and it will take you to a video or multiple videos of pad placements that can help you through a lot of your pain. Now, that being said, we also do have a YouTube channel where you go, and that's also going to be linked on our website, and you can look at the protocols there. Those are going to be a little bit more advanced, more detailed. Some of those are up to 5 to 8 minutes, give or take. And there's also some performance protocols on there as well, and those are continuing to grow. So there you go.
Awesome. Good stuff. So if somebody's having, let's say they own an RX or a PRS, and they're having questions, I think the concept is, email us at info@arpneuro.com. And obviously it helps us build a library. It helps us, research and get different protocols to make sure that you have access to any and all available protocols to help whatever the condition may be.
Correct. Well said. And that's one of the reasons we do have some of the protocols that we do. Some things that we just don't think about or we take for granted that you already know. And someone has already asked that question, has emailed us, and then we made a protocol out of it. So yeah, keep them coming.
Love it. Jake, get to that steak, my friend. You
It's
deserve
calling
it.
my name.
I love it.
You get your rest in.
I love it. All right.
Appreciate everyone joining in. Matt,
Good
you have
stuff.
Anything final to close us out on?
I think that's the fastest 30 minutes that I've seen. So we'll continue to do these. Look for the next one, and I hope everybody has a great Monday evening.
Sounds good. Matt,
All
good
right.
to see you again.
Good
and
work,
thanks
Jake.
everybody for joining in. Thank you, sir.
Take care.